कृष्णा दी, हाँ आपकी आवाज नहीं आ रही है। कृष्णा दी आपकी आवाज नहीं आ रही है। आप आपके हुक्म के बिना प्रोग्राम शुरू नहीं हो सकता। हाँ जी,
I'm not able to hear anything.
मेरी आवाज आ रही है आपको? किंतु हमें आपकी आवाज आ रही है।
Okay, Dr. Patwari, I think you should start the introduction and let's move because she may be having some problem with her
ओके ठीक है, हम लोग शुरू कर दे प्रोग्राम।
audio system.
आप एक बार वापस ज्वाइन करो ना दूसरे।
मैं हूँ वहाँ पे।
हाँ, दैट्स गुड।
Hello everyone.
Shall I? Yes, yes, we can hear you.
Hello everyone.
Yes, ma'am, we can hear you.
Hello.
हाँ, हम लोग सुन पा रहे हैं आपको।
Hello.
आपकी आवाज आ रही है, बोल दो, इंट्रोडक्शन दे दो। हाँ।
Secretary sir, as Dr. Sanyal also told, the president has arrived. We please start.
As a president of West Bengal Society for Study of Pain, I welcome you all. And you know, Lignocaine we are using for a long time. Everyone is using as a local anesthetic. It is anesthetist and every surgeon, and whenever needed, we are using. But something we don't know or we are not much of knowledge about the Lignocaine. Today we have talk on the Lignocaine. Please enjoy the talk and listen. Please start. Thank you.
Thank you very much, President ma'am. I would request Dr. Goswami sir to chair the session and introduce the two speakers and do the moderation. Thank you very much. Dr. Goswami sir, please. Dr. Goswami sir.
Yes, I can hear. So I request our scientific secretary, Dr. Ramapati Sanyal, with your kind permission of the secretary, so he can introduce the speakers. Because the speakers can start the program after introduction by our scientific secretary, Dr. Sanyal. Dr. Ramapati, please.
Dr. Ramapati sir, please.
Okay, thank you everybody. Let's start off. Lignocaine is a very common drug that we commonly use in our day-to-day practice, especially in pain medicine. It has been used through various routes. Now today our topic is a very queer and an interesting one. It is not about the anesthetic properties of lignocaine, but actually the anti-inflammatory properties. To conduct the session and to take it forward, we have two very promising speakers on the list of WBISSP in West Bengal. One is Dr. Tonu Moy, who will be elaborating on the basics of lignocaine pharmacology, and then followed by a more investigative nature of talk given by our assistant professor of anesthesiology, Dr. Devanjali Roy. So first I will invite Dr. Tonu Mollik with the basics of lignocaine pharmacology. Thank you.
Dr. Tonu Moy. শুরু কর তাড়াতাড়ি।
আচ্ছা, ঠিক আছে।
Please upload the presentation.
Yes, Dr. Tonumai, please upload the presentation and please carry on. Are you having any problem? Thanks.
তোর আওয়াজ শোনা যাচ্ছে না, তুই শুরু কর বলা, স্পিকারটা অন কর, মাইকটা অন কর।
Yes, Dr. Tonumai, are you having any problem? Because we cannot hear you.
Yeah, I'm talking with Dr. Tanumai. He's having some issues. Tanumai, please start. আবার একবার চেষ্টা করো। Yeah, please.
Sanjada, can I see the persons who have joined on screen?
I don't think I can control it from here
Okay.
when somebody is presenting.
Oh, okay, fine.
You can, yeah, now since he has stopped presenting.
Okay, fine.
Apparently, Tanumai is having some issues, so he should be able to rejoin and restart the talk. So just please bear with us.
Sanjada, I would like to request some fellow friend of Tanumai to call him and ask him what's the problem exactly he's facing.
I was talking with him. He said that he is saying hello, hello, but nobody is responding because I had called him.
Joined. Okay, Dada. Tanumai joined. Yes.
তোর আওয়াজ শোনা যাচ্ছে না।
His speaker seems to be muted.
তাহলে তুই শোন, তুই এক কাজ কর, আমি আমার ফোনটা মাইক অন করে দিচ্ছি, তুই এখান থেকে শুনতে পারবে তোকে সবাই, ঠিক আছে? আমার মাইক থেকে শুনতে পারবে।
You have to unmute your speaker.
তোর এটা মাইকটা আনমিউট কর। Tanumai will be talking over my phone.
Somebody should call him and tell him to.
I'm with on phone with Tanumai. So Tanumai will be talking from my phone. Yeah, Tanumai, please start.
Okay. Very good evening. I'm sorry for the inconvenience. I think there might be some network issues or something. So today my topic is, can everyone hear me?
But please, Tanumai, say a little bit slower. You are.
Okay. Yes. Okay, ma'am.
Can we see your slides?
I have shared it.
স্লাইডস গুলো আমি দেখতে পাচ্ছি কিন্তু।
দেখতে পাচ্ছো?
হ্যাঁ।
Okay.
You can't see the slide. You have to pin.
No.
Wait, just a moment. Can you see it now?
I can see the slide.
You can see the slides now.
I can see the slide.
Okay, please continue, Tanumai.
Okay. Good evening, everyone. The topic is Lignocaine basic pharmacology. So to start with the basic pharmacology, first what I'll do is the classification of ALAs. The basic structure of local anesthetic contains of a aromatic chain, which is a lipophilic part here, which is connected to a tertiary amine, which is a hydrophilic part here, by an intermediate chain. And upon that, we divide the local anesthetic into ester group when the bond is an ester bond, and amide group when the bond is CONH or amide. How to remember which local anesthetic is what? We have to remember that amide has got an I, and that is why when there are two I's in the name of a local anesthetic, it becomes amide group of local anesthetic like lidocaine, mepivacaine, bupivacaine, and so on. Now our area of interest is lidocaine. Lidocaine was the first amino-amide type of local anesthetic which was synthesized under the name xylocaine by Swedish chemist, and it was approved by FDA in 1948 for its clinical use. And that was the chemical formula of lignocaine. To start with, to say the mechanism of action, before doing that, what I will say is all the local anesthetics are not soluble in solution. So they are marketed as hydrochloride salt to make it soluble, and they are kept in an acidic pH for solution.
Sorry, I am interrupting a little bit. I am interrupting. So, Dr. Patwari,
Just a moment. Yes.
please unmute yourself and all others. Otherwise, who have not unmuted, they will be seen. So, please unmute yourself also and also others so that we can see Tanumoy.
The problem is if I unmute myself, Tanumoy is speaking from my phone, sir.
But the problem is that Tanumoy slide is not seen.
Tanumoy, I think you have to.
Sir, there is a solution for that. If we just put the Tanumoid name,
Yeah, do that.
then his slide will be visible on that. Means we have to pin the Tanumoid screen.
WhatsApp
Just touch the Tanumoid name, and then the Tanumoid screen will be visible.
Okay.
Yeah, just.
I think he is joining again.
No, he's sending me his slides. I'll be playing the slides for him.
Okay, sir, your email ID.
S Patavri, SPAT. নাহলে WhatsApp করে দে আমাকে। SPATA.
Devanjali, unmute yourself.
Mute yourself, rather. WARI, that's it, at Gmail.
Okay.
স্যার আনমিউট করব কেন? আমি তো মিউট করেছিলাম। কিছু বলবো?
হ্যাঁ বলো।
না তুই কি কিছু কথা না মিউট কর তোর
হ্যাঁ সেটাই।
Yeah, I think Tanuma has again left. I don't know why, because we are going on smoothly, we are cruising fine.
Yeah, Tanuma is having some issues. What he is doing is he's sending me his slides. All right. So that I can present the slides and he will do the talking part. So just
I am stopping the screen sharing.
Yeah, that's good.
There is a network issue actually. It's taking so much time to upload.
Just a moment. Let me see. I don't know why you have landed me.
I have stent just now.
Can we do it the other way around? If with the house of with the permission of the house. Ramapati, can we have the Devanjali session before? I think Devanjali will do the anti-inflammatory part. Huh?
Do whatever you like, but let the discussion proceed. That's what the aim is.
So Devanjali, you please start. You start with the presentation, please. Tanumay? Hello?
Just a second. I'm starting. Just a second.
Tanumay? তুই এক কাজ কর, I think Can you share this? দেখি আমার এটা আমার
But
নিজের
I'm
And
just
fine.
including,
Okay, okay.
I'm just
Bolun, bolun.
including,
আমি দেখছি
is it possible to pre-check all these things? Is it not possible? I'm not very sure about possible to pre-check before you start off.
Sir,
yeah, it
possible.
can be done.
Yes, I think so. So in
Tanumoy,
future,
I
one
had
speaker should do that to pre-check before he starts off.
yes, sir.
Entering at least 5 to 10 minutes before to pre-check and then enter. This is my request to all the speakers, all the members, whoever will be presenting in future. Please pre-check 5 minutes before you enter. Thank you. Devanjali, please carry on.
Okay, let me start my slides. Let me share my slides. Can you see my slides? Can all see my slides? I have started sharing. Please respond. Can all of you see my slides?
We see your screen, not your slide.
I have started sharing. Can you see it now?
Devanjali, no.
Okay, let me check it once again. It's a problem of, I think,
No, it is not a problem. That's why I had asked you to check.
I have checked it, Dada, with Gargi. I have
Yeah, so I was there for last 1 hour. I was here.
it is showing that you are presenting. So I have started.
Probably you have to minimize your screen and start the slide on the background. That's why we cannot see the slide.
Now you can see it.
Coming on its way.
So fine with it. Can I start now?
We don't
No, we
see
can
your
see a
screen.
blank. We can see a blank screen. There are no slides on this. There are no slides on this. This is just a blank screen.
How could be? Just a second, you are. Now, can you see it?
Yeah. Open your slides.
Is it
Open your slides
okay.
in the main window.
I have opened it, Dada. Dakho.
It's a blank screen coming. It's a blank screen coming now.
Oh. It is showing that you are presenting to everyone. Okay.
আমার এখানে আসছে দেবাঞ্জলি রায় is presenting.
So I have minimized it.
আমার কাছে আসছে দেবাঞ্জলি রায় is presenting. হ্যাঁ ওইটাই আসছে তো এইবারে now open your slides in full screen. Now open your slides in the full screen.
Probably you have to click the arrow, upper arrow.
No, you have to, yeah.
Okay. Now let me start. Is it visible now?
No, we can see only you.
You are visible.
How can I be visible?
So, Dr. Patwari, my suggestion is that from next session,
Sonuma is there, I think.
I think please give a trial session with the speakers.
See, I'm here for last 1 hour, more than 1 hour, and I have talked with both Tanumoy as well as Devanjali.
And also they should give a trial before the actual time comes.
Okay, fine. Devanjali, click on the
Can
present now. Click on present now. Just follow what I'm telling you. Click on present now.
করেছি, ক্লিক করেছি।
Huh. Now what you are getting?
গেটিং যে ইয়োর ফুল স্ক্রিন উইন্ডো এরকম পাচ্ছি।
হ্যাঁ, ওটাকে ফুল স্ক্রিন উইন্ডো করো। Open your presentation full screen on another thing. Alt tab টা press করো।
now it has come.
Yeah.
বাস
Fantastic. Please make it full screen.
আর কিছু করিস না বাবা, এই চালিয়ে যা।
আমি বলবো স্যার, should I start?
Please start.
Okay. So I was supposed to say in the second. Oh, sorry. Good evening, everybody. First of all, I would like to thank the organizer, mainly our very close to heart, Ramapati sir, Sanjay da, and all those to keep faith on me to discuss this topic, because this topic is what we practice, but we actually don't know all the mechanism or the background, or what we don't practice because we don't know the effect of it. And as I was supposed to say in the second, so I omitted some physiology, pharmacology. I thought that Tonumoy would mention it. So I directly jumped to the main topic which I was about to tell. So, okay, let's start. What we know that Lignocaine, what we commonly know that Lignocaine is an enlisted drug in WHO essential drug list as class 1B antiarrhythmic and local anesthetic agent. This much all we know. So what I was supposed to say is anti-nociceptive, immunomodulating and anti-inflammatory properties. For this, when I heard that I'm finally going to say this, I have searched a lot of literature through PubMed, MBS and Medline pharmacology textbooks and so many online sources. Ultimately, what I am going to tell you, synopsis of Lignocaine's mechanism of action, focusing on its anti-inflammatory, immunomodulating and analgesic effects. So basically, these three things are not separate rail lines, that those will go parallelly. Anti-nociceptive, anti-inflammatory, ultimately all these things will pull to the analgesic effects of these drugs. And along with that, some additional effects also will be there. To start with the basics, before discussing all those complicated things, we should at least memorize once these things, that is the action potential. So at the nerve end, the resting membrane potential is minus 70 millivolt. I am mentioning it specifically because if there is any anesthesiology, PGT or pain fellow, it comes in the physiology exam. So minus 70 millivolt is the resting membrane potential when stimulus comes. Up to minus 55 millivolt, the threshold maintained. Then after 55, suddenly action potential rises. That is depolarization. At plus 40 millivolt, that it's the overshoot. Then repolarization starts, followed by hyperpolarization that goes up to minus 90 millivolt. Then it comes to the resting state. That means resting membrane potential again, which is minus 70 millivolt. So what happens during these action potentials? Where does sodium go and where does potassium? See, when the threshold stimulation comes, sodium channels opens slowly. Slowly it starts to enter into the cell. And when the minus 55 millivolt crosses, that means the threshold stimulus crosses, there is a sudden rise of entry of sodium channel with very force and very speed into the cell. And potassium channel starts to go out, begins to leave the cell as well. And at plus 40 millivolt, when there is sharp rise of action potential or depolarization, the sodium channels becomes refractory. So no more entry of the sodium channel into the cell. At that time, what is called repolarization starts, and potassium continues to leave the cell slowly, gradually. It becomes to the resting membrane potential. And when the potassium channel close, sodium channels goes to the resting phase. This is the basic. To discuss all the anesthetic property, analgesic property, and some few inflammatory properties. We have to keep this action potential in our mind. So what does the lignocaine do? As all the cell membrane has lipid bilayer and protein unilayer coat, what is called cellular coat, as being the lipophilic local anesthetic, it enters into the cell membrane, it acts on the sodium channel in the resting phase and delays the entry of sodium channel, and also potassium current, inhibit the exit of the potassium current. This is the basic mechanism. I have not put more slides on it because pharmacology will be discussed by Kunuman. So from this point we can start anti-nociception, blockade of neuronal sodium channels and potassium currents, what I have told. In the same way, blockade of presynaptic muscarinic and dopamine receptors. How? The muscarinic and dopamine, even other receptors, are kept embedded into the lipid and protein coating of the cell membrane. So, blockade of sodium and potassium currents centrally at a spinal cord level, specifically targeting the spinal dorsal horn neurons. Now, the question is, this lignocaine, what in the peripheral nerve, it acts by blocking the sodium channel. These sodium channels and the central nervous system, that is dorsal horn of the spinal cord, sodium channels are the same or not? So many studies have been done on it, but what I have found in the Anesthesia and Analgesia journal in 2014 August, that it was a very huge study and a very popular study. It showed that in A delta and C fiber neuron cells, lignocaine acts on tetrodotoxin and tetramethyl ammonium sensitive sodium channel. These two specific chemical sensitive sodium channels upon which sodium lignocaine actually acts in the central nervous system. So, what are the uses of lignocaine in pain? Come to one by one. First is post-herpetic neuralgia. So, to search the use of lignocaine in pain, I have found so many articles, but I have kept the Cochrane analysis, systemic reviews, and or the recent studies, because to mention so many things in this 10 minutes is not possible. So, first of all is post-herpetic neuralgia. Daily intravenous lignocaine at a dose of 4 mg per kg for 5 days enhanced the outcome of post-herpetic neuralgia treatment, reduced the amount of analgesic medicine, and shortened the length of hospital stay with no obvious adverse side effects. It was a big study done in very recently, August of 2019. Topical lignocaine for the treatment of post-herpetic neuralgia. It was a Cochrane systemic review done on 2017, published on April. And after that, I have found another very big study. Actually, it was a drug trial. A study with lignocaine 5% medicated plaster in patients suffering from post-herpetic neuralgia. It was under phase 3 trial in USA, sponsored by Grunenthal GmbH, updated on August 2018. And after that, in 2019, this 5% xylocaine medicated plaster for post-herpetic neuralgia was approved by FDA. Second use is post-operative pain in laparotomy. Basically, it is a kind of preemptive analgesia, though this concept has a big issues and confusion also. Continuous local anesthetic wound infusion for post-operative pain after midline laparotomy for colorectal resection in adults. This study was done very recently in the last year, 2019, and it was Cochrane database systemic review. They have searched a lot of articles, and all of them has concluded that it reduces pain and also delays the time of rescue analgesia. Number 3 is what we commonly use, we dialgologists commonly use in fibromyalgia. Repeated intravenous lignocaine infusions for patients with fibromyalgia. Higher doses of lidocaine have a stronger and longer lasting effect on pain reduction, was done by a lot of scientists, and it was published in Pain Medicine very recently, June 2020. So, in fibromyalgia, in our institution also, we have used lignocaine as an intravenous infusion to treat fibromyalgia. And number 4 is eutectic mixture of local anesthetic in painful burn dressing and painful leg ulcer. So it is also a big study which was published in International Journal of Burns and Trauma. They have concluded that EMLA along with fusidic acid for dressing in burn has significantly reduced the amount of analgesic at least 8 hours in mainly the children and the young adults. So these are the main use what we use, but it should not use in our day-to-day practice. It needed to be used more because we have seen from these studies that these are promising for the lignocaine. Now coming to the anti-inflammatory effects. I have also searched a lot of articles and it has been attributed that lignocaine's powerful anti-inflammatory properties may be superior in many ways to NSAIDs and steroids. Unfortunately, the specific molecular mechanisms involved in the migration of polymorphonuclear granulocytes and free radicals are not known. But that sodium channel blockade, what we were discussing now, it can be excluded. This is not the cause how the anti-inflammatory property of lignocaine is exerted. Now, what does it do exactly? It blocks the release of interleukin 1, which is an anti-inflammatory mediators acting on PMN granulocytes, which in turn activates phagocytes, respiratory burst, degranulation, and chemotaxis. It has a problem also. Anti-inflammatory property also causes carcinogenicity and mutagenicity of the lignocaine. Yes, it has, but this is beyond our discussion of today's discussion. Now coming to the picture, effects of interleukin 1 blockade on the cellular function. See what happens on the endothelial cell, smooth muscle cell, hepatocytes, lymphocytes, in all the cells. As it blocks the interleukin 1, it reduces the inflammatory process. But in case of cancer and stem cell, you can see it inhibits the epithelial cells to mesenchymal transition. So there is chance of oncogenesis and reduced procoagulant production. Another thing is that in some in vivo studies, it has been found that high concentration lignocaine in high concentration lignocaine inhibit histamine release from human leukocytes, mast cell, and cultured basophils. So mainly, it has effect on macrophage, PMN granulocyte function, and also inhibit the release of some critical markers of the inflammatory cascade. Another thing is, along with the inflammatory cascade, it has also some effects on phospholipid A2, COX, and LOX. It interacts in a dual manner. Like in low dose, it inhibits it stimulates in low dose. It stimulates the activity of the phospholipase A2, and in high dose, it reduces the activity of the phospholipase A2. It inhibits the spontaneous prostaglandin biosynthesis, mainly EGF2. It has been found in a vitro study. And lignocaine administration significantly inhibited prostanoid release and biosynthesis from human gastric mucosa in response to experimental damage. It was another in vitro study. So these anti-inflammatory properties of lignocaine is under study. Exactly on which mechanism it is not known yet. So to conclude or to take a look, there are anti-nociceptive and analgesic effects of lignocaine by blockade of neuronal sodium channel and potassium current, blockade of dopamine and muscarinic receptor, reduction in the excitatory amino acid, reduction in the thromboxane, release of endogenous opioid peptides, glycine inhibitor, release of ATP adenosine triphosphate, and inhibition of cyclooxygenase and lipooxygenase pathway. So what I felt personally after going through all these articles, we should remember the basic mechanisms because inflammatory cells are also cells. Those cell membrane has also those lipid and protein bilayer by which lignocaine can act. So there is a scope. These are my references. So there is a scope of both qualitative and quantitative research on this particular topic, that is the anti-nociceptive and anti-inflammatory properties of lignocaine. Thank you for taking lignocaine in various ways. Thank you for your patience. Have a nice day.
Thank you, Dr. Devanjali, for such a good discussion on the lignocaine on its frontiers. Uh, so, since we had a problem with the audio and everything, we go back to the basics after we had discussed advanced literature on lignocaine. So, I'd request Tanumay to finish his discourse on the basic pharmacology of lignocaine before we open the session to the house. Tanumay to continue. Thank you.
Sir, am I audible, sir?
Yes, you
Yeah,
are
you are
audible.
audible.
I'm
Okay,
muting. I'm muting myself.
Okay, is the slide visible?
Yes, Tanumay, please go ahead.
Okay, sorry for the inconveniences. There was some problem. So my topic of presentation is basic pharmacology of lignocaine. So to start with, say something about local anesthetics. So there is a basic pharmacology, basic chemistry. There is a lipophilic aromatic amino acid part, which is bounded to the tertiary amine or the hydrophilic part by different bonds. If it is an ester bond, we call it an ester local anesthetic. And if it is a CONH or amide bond, we call it a amide local anesthetic. Now, how do we know or how do we name it? So we have to remember this. In amide, there is one I. So in the local anesthetic which are of amide group, there are two I's in their name, like lidocaine, mepivacaine, bupivacaine, etidocaine, and ropivacaine. Now, our area of interest is lidocaine today. It was the first amino-amide type of local anesthetic. It was synthesized under the name xylocaine by Swedish chemist in 1943, and it got FDA approval for clinical use in 1948. This is its chemical formula. Before going into the mechanism of action, I would like to say that all the local anesthetic agents are not soluble in solutions, and that is why they are marketed as a hydrochloride salt for making it soluble in administrable forms. And also, they are kept in an acidic pH for their stability. So, if it is a lignocaine with adrenaline combination, it is even more acidic because epinephrine needs an acidic solution to remain stable. Now, what we know is when we administer the drug, Devanjali madam has already stressed upon the fact that the drug, when it is administered, I'll skip my slide and show you one figure that it divides into a H plus ion and the base, the local anesthetic base. This local anesthetic base is important for the penetration through the lipid bilayer. It enters the cell, goes inside and blocks the sodium channel to decrease the sodium entry into the cell and subsequent depolarization and action potential generation. Now, this sodium channel, they have got multiple types like 1.6, 1.1 to 1.7. They are present in CNS and DSG and everywhere, but the basic mechanism remains the same. We have to remember that there has to be a considerable, at least 3 nodes of our anvir nerve should be blocked for effectively blocking the action potential generation and firing of the nerve. Now, the sodium channels are in 3 forms. One is resting, one is open, and another is inactivated. In the inactivated form, the lidocaine has got its highest affinity for the receptor, and in the resting form, it has got highest penetration. So this kind of explains its frequency-dependent blockage that I'm going to say later. To say something about the sodium channel details, it has got one major alpha subunit which has got the conductance property. That means it transmits the sodium channel through it, and there are multiple beta subunits which kind of regulate the opening of the alpha subunit. So frequency dependent blockade it is said that when the frequency of a nerve to generate action potential is higher, there is higher affinity of local anesthetic to the sodium channel, and there is higher onset. The effectivity of local anesthetic on that nerve is better. That is why what we say is when the supraclavicular brachial plexus block has been administered, if you ask the patient to move their fingers a little bit, then the onset of action becomes earlier. It is also said that other than the sodium channel, there has been other side of actions like potassium and L-type calcium channels. L-type calcium channel, we know that they are present in heart, and that is why lignocaine can decrease the heart rate. And it is also, helps in the anti-arrhythmic action of the lignocaine. Now, to say something about the minimum effective concentration and differential conduction blockade, minimum effective concentration is the concentration of the local anesthetic, which is minimum concentration of the local anesthetic, which is needed to stop the action potential or conduction. Now, this CM is different for different nerve fibers. The motor fibers has got its CM twice as much of sensory fibers, and that is why we can administer various concentrations of lignocaine and do selective blockade of first sympathetic, then sensory, then sensory or pain, whatever, and then motor. So this is a differential conduction blockade. What are the factors influencing lidocaine action? I've already told that it is marketed in a acidic pH. So that is why we might need to alkalinize the solution with sodium bicarbonate to increase its rapidity of onset. The other thing is, if the pH is in acidic form, it is said that the pKa is the pH of lignocaine, or pKa of a local anesthetic, is the pH of the local anesthetic at which the local anesthetic agent is 50% available for in unionized form. That means 50% active form. The pKa, as close it is to the physiological pH, more will be the available unionized form for better penetration into the nerve tissue. Now the lignocaine's pKa is 7.9, and it is quite close to pH, our physiological pH of 7.4. But if there is an abscess, there is an edema or some inflammatory process going on into the target area, and we administer lignocaine, the unionized form decreases and ionization increases. So the effectivity of local anesthetic decreases by a lot. To say the pharmacology, it has got a half-life of around 1.6 hours, it's extremely lipophilic, widely distributed throughout into the body. The pH of plain solution is 6.5, vasoconstrictor containing solution is 5 to 5.5, and it has got a plasma protein binding of 60 to 80%. Now to say about pharmacokinetics, once we deposit the local anesthetic into around the vicinity of particular nerve, how it will be distributed, it depends upon many factors like where it is administered, what dose it is administered, what concentration and volume, and whether we have added any vasoconstrictor agent to it or not, apart from patient factors. Now, uptake to the tissue, the lipid solubility has got a great role to play, because as much lipid soluble the local anesthetic will be, more will be the tissue distribution, less will be the plasma concentration of the drug available after the distribution. So first it gets absorbed into the systemic circulation, then gets redistributed to the tissue rich in vascularity, and then it gets and stays trapped in the tissue depending upon the lipid solubility. Pulmonary extraction is also a factor that lidocaine has got. There is a huge pulmonary extraction of lidocaine when it goes through the pulmonary circulation, so that the available concentration into the systemic circulation is less. It is mainly metabolized by hepatic route by oxidative dealkylation to monoethyl glycine xylidide, which has got 80%, which is the active form. It has got 80% efficiency of lignocaine. It has got antiarrhythmic action, and that is why once we stop the lignocaine infusion in case of ventricular tachycardia, the action persists for a longer duration of time. And it is further metabolized by xylidide, which is usually an inactive form, only 10% activity of the original lignocaine. Excretion obviously mainly via the hepatic elimination by metabolism, and the metabolites get excreted by urine, and less than 5% are excreted unaltered via renal route. pKa is 7.9, I have already mentioned. These are the available formulations: 1.5% and 2% lignocaine with adrenaline, 2% and 2% xylocard, 4 and 5% lignocaine spray, jelly, emla, and lignocaine patch. So uses in anesthesia. Everybody knows about regional anesthesia, surface anesthesia, topical, Bayer's block, tumescent anesthesia, and infiltration anesthesia. All the intra-op and peri-op analgesic usage apart from them. There are excellent usage in neuropathic pain. Lignocaine patch already, Debanjali madam has already mentioned that Lignocaine patch has been FDA approved for post-herpetic neuralgia, and it is believed to be very useful. And we do in our institute a lot of intravenous desensitization for patients who are not being able to the pain is very severe. And also in fibromyalgia patients, we really do it a lot. And antiarrhythmic property that I've already told, that it has got a use in the control of ventricular tachycardia, and it has been incorporated as an alternative to amiodarone into the ACLS guideline, latest ACLS guideline. Adverse effect, well, the neurotoxicity, the transient neurological weakness and cauda-equina syndrome, we don't expect this at this point of time to see, because it was 5% lignocaine, which was used for central neuraxial blockade, which gave all the problems. And also there was initially introduction of spinal microcatheter and continuous spinal infusion with 5% lignocaine, which gave rise to cauda-equina syndrome, and both are obsolete now. Spinal microcatheters are not available at this point of time, though the resurgence are coming back because we are using bupivacaine more and more. And then the thing that is most deadly is the local anesthetic systemic toxicity. I will just touch upon a few points that we have to first ensure that we have to prevent. So we have to know which are the patient populations we are using the local anesthetic. We have to know whether the patient are of they are children or old age, or having kidney issue, chronic renal failure or liver disease or heart disease, and malnourished patients with protein allergy, malnutrition, and these things. These people are more prone to get local anesthetic toxicity because of various pharmacodynamic changes. Now, for them, we have to decrease the dose. Another thing that I have forgotten to mention is the maximum dose of the lignocaine, the bolus dose, the one dose we give during injection is said to be 5 mg per kg if it is only lignocaine, and if it is lignocaine with adrenaline, it is 7 mg per kg. But this dose decision, the dose finding study was done on epidural route, the original study. And we all know that when we compare the plasma concentration of lignocaine after various different local anesthetic blocks in various routes, we know that intercostal blocks gives the highest amount of plasma concentration, followed by caudal, followed by epidural, followed by brachial plexus, supraclavicular brachial plexus block. So this dose has to be modified according to the route or according to the site we are going to administer. It is not a fixed dose. So what block we are planning or what injection we are planning, accordingly adjusting the dose is also important to prevent local anesthetic systemic toxicity. We have to, while administering, we have to get all the monitors ready, attach the monitors, keep on talking to the patient, aspirate every 3 ml and then inject, and if possible, and it is Astra recommendation to combine a little bit of adrenaline as a marker for intravascular injection while injecting, because like what we do for epidural test dose, because if the vein is collapsing and my needle is into the vein, sometimes even if we aspirate, we do not get the blood. So then the adrenaline gets let us know that the needle tip is into the vessel. So this is very important. And when we eventually, even after taking all the precautions, we might land up into a local anesthetic toxicity, we have to remember ABC. We have to maintain the airway, we have to maintain the breathing, we have to, if there is a convulsion, we have to control it with midazolam, but not with propofol, because propofol will cause more hypotension and complicate the scenario by causing acidosis. And then we have to administer 20% intralipid at the earliest sign of local anesthetic toxicity as per ASA guideline. And obviously the dosage varies from the less than 70 kg or more than 70 kg, and accordingly we have to take a step. We have to be very vigilant even post-operatively and intraoperatively while doing any local anesthetic injection for the local anesthetic systemic toxicity, because it is a life-threatening situation. Fortunately, Lignocaine has got a good CC to CNS ratio. That is why the cardiovascular complications are less with lignocaine in comparison to neurological complications. So probably we have got a window of safety in comparison to bupivacaine. So that is what my presentation was. Thank you for your patient hearing, and sorry for the inconvenience caused at the beginning of the presentation. Thank you.
Thank you, Dr. Manumar, for your elaborate discussion. Now, discussion is the topic is open to the House. If you have any questions to ask.
So do you recommend to keep the intralipid in the operation theater? Do we routinely keep this while giving these local anesthetic regional blocks or intercostal blocks? So I would ask the speaker as well as the learned audience here. So how many of us are are prepared for prevention or managing the toxicity?
Sir, ideally we should keep it ready. Ideally it should be available. But again, the availability in India is an issue. So in all ideal scenario, as per ASRA guideline, wherever we are doing a local anesthetic injection, it should be available. It should be made available.
But in practice, rarely it is available, and we have seen it. But we have came across the complications of convulsion mainly, and lignocaine toxicity mainly because of the intravascular spread. Maybe sometimes surgeons are called that this lignocaine, that is adverse reaction of lignocaine, not adverse reaction, there is a adverse reaction like other drugs, this has occurred, but it is due to inadvertent injection, not due to the inadvertent property of the drug. 90% cases, because inadvertent injection to the vessels is causing the problem, then we are calling that is lignocaine is allergic to lignocaine. Another thing, can you explain about this tumescent anesthesia? You told that is tumescent anesthesia, lignocaine is used. What is that? Just explain.
Okay, tumescent anesthesia is actually what has been done is in liposuction. What they do is they make a cocktail of a drug. They put around 20 mg per kg of lignocaine, around 1 vial of sodium bicarbonate, and around I think 5 or 10 vials of epinephrine into a 1 liter of solution. And what the surgeons do is they put a skin nick, put a probe, like what we do is what we see is scopy, urethroscopy is done, or the dissection is done. They put it into the subcutaneous tissue and pass it into the subcutaneous fat for a considerable time, so that there is a hydrodissection. There is decreased vascularity of the subcutaneous fat when they dissect out, and that there is less blood loss. So initially, it helps in the decrease in blood loss, but what will happen is the lignocaine, when it is given, it stays into the system for around quite a long time, and it is not uncommon to have local anesthetic systemic toxicity around 24 to 48 hours later post-op. So this is actually a high risk.
Because they cross the limit of toxic dose also.
Yes.
Okay. And fantastic presentation.
Yeah, regarding I think regarding the using of intralipid, it is definitely in one of the ASRA guidelines. But what happens is, when do you use an intralipid? The amount of lignocaine or the amount of local anesthetic has to be very high before you start using the intralipid. And number two, there are evidences, but it is not this is not the primary. The very common reaction is convulsion and loss of consciousness. So by taking only preventive measures or taking basic resuscitative measures, most of the cases are solved as such, because you don't inject that much of a local, because we are using within a safe dose. Even if that goes, so intralipid is a very extreme measure. So it is not actually indicated. Obviously, you should have, according to the guidelines, you should have an intralipid in your OT. But this is not to be said to be an absolute requirement, as we have seen from our daily to day practice. So the most common thing is convulsion and loss of consciousness and all those. So we can use only by using a resuscitative measures. Most of them make good. So this is most probably, I think from my personal end, this is one of the reasons why we don't look for intralipid before you start off with our regional anesthetic of injecting lignocaine also.
Sir, there has been a actually question. There should be preempting in the chat box actually. There should be preempting signs of lignocaine toxicity such as paresthesia before convulsion. Guidelines mention this. Actually, yes, there has been a like CNS excitability followed by depression. So before the convulsion sets in, there is perioral numbness, tingling, tinnitus, and everything. But I have done one supraclavicular brachial plexus block, and I had injected only 3 ml, and the patient became silent and started having convulsion. So it was probably intravascular. There was nothing on aspiration. So it was like I didn't have any point, though I was. It was back in the year of 2017. But yes, it happened without giving me any preempting signs. So usually it is said that the ASA guidelines said that the monitor should be attached. Our eyes and ears should be lent to the patient under the monitor while injecting, so that we can pick up whether there is a tachycardia, whether the patient is starting to have a little bit delirium, patient is starting to say that yes, I'm having some tingling in the ear, in the around my lips and something like that. But it might happen without giving any warning sign also. So we have to be very, very, vigilant about it.
Yes, Tanuma, you are right. So when you are needing an intralipid, most probably you have not lent your ears and eyes initially to the patient. That is what might transpire too.
Probably.
So in
another thing I would,
yes.
Hello. Yes, another question is that how to assess the sensitivity, whether we all do this, or how to assess the lignocaine sensitivity. Do we really give a skin test or any other test before should we do?
Sir, to answer that, actually, in my PG days, what we used to do is we used to, before sending the OT in the PAC chart, we used to tell them to do a xylocaine sensitivity test intradermal, like what we do for any antibiotic. We inject intradermal and put us around and see whether it is doing it or not. But the thing is, the allergic reaction to amide local anesthetic is very rare. It is mostly for esters, and we do not use it. So, and probably, even if the xylocaine sensitivity test is done, it is very rare. I mean, we have not seen any. I do not know whether that sensitivity test, if it does not come positive, there is any chance that it will tell us that intraop it won't happen. But anyways, lignocaine has got a very rare incidence of this thing, allergic reaction. Intravascular, yeah.
Yes, this is all about the basic pharmacology. Coming to anti-inflammatory properties, I just because Devanjali just flashed at the reference, I could not get through. There's a good meta-analysis by Karachev et al. Around 2006-2007, as far as I can remember, on the anti-inflammatory properties of lignocaine they have put up. And it's an interesting read. Now, regarding what the main topic was today, Devanjali has quite well explained that there is the interleukins that are responsible. There are prostaglandins that are responsible. Actually, what happens is, first, if you look at the structure of lignocaine, the lignocaine has a ring structure. Now, any of the ring structure molecules have to have some anti-inflammatory properties. If you take NSAID, they don't have the structure of the steroid, but they have definitely phenol structures in them. So any phenol structure as such will have some anti-inflammatory properties if you come to the structure as such. The second one is that it has been found that the lignocaine causes a modulation of the CD molecules on the neutrophils. So what happens is this interleukins, which takes onto the CD molecules, are hindered, and therefore the neutrophils, as well as all those cells, they don't marginalize and they don't reach the spot to have the respiratory burst. That means they do not release prostaglandins, they do not release ROS, and all those which in time or in consequence is the progenitor of inflammation. And the third part, which has been found in the studies, is lignocaine, since it prevents the transmission of the electrical impulse, does not release glutamate presynaptically. So glutamate is one of the factors. There is a study which they have injected kainite into the intraperitoneal and found that the glutamate is one of the inflammatory factors which, because lignocaine does not, by decreasing the transmission, the electrical transmission, does not release, let the nerves, especially the C fibers, release the glutamate, and therefore there is an anti-inflammatory effect. And this is most probably one of the reasons why IV lignocaine, when you are using for so many things, you are using for fibromyalgia and all those, apart from what the mechanism is, could be one of the reasons. Now there's a flip part to it, like lignocaine in this concentration is inhibiting the neutrophils, and therefore there are chances that you can have an infection. But at slightly higher concentrations, lignocaine also have antibacterial effect. So the antibacterial effect is again helps in controlling the inflammation. So these are important parts and important points where lignocaine acts as an inflammatory. I think there are no others, like all others have been identified very well. Like yes, yes.
I was going to ask Devanjali. I'm sorry, I could not be there during Devanjali's speech for the poor transmission here, but I do not know whether it was covered that during the prolotherapy, is there any rationality of giving lignocaine also? So that's sometimes it is given for like PRP or those other things. When we invite inflammation, so whether should we also give lignocaine or we should not give?
Sir, I have not touched this point, and in prolotherapy use of lignocaine, I have not mentioned about it. I have to go through it separately. But as the question suggests, as we want to invite inflammation, we can use it. But I have to see the supports, the research works and supports. I have to check it, and I will let you know after that. Once I read it properly, I will let you know.
Okay, if any you are expert, you can add on this, like Dr. Sanyal. Sure. Why not?
Sir, thank you, Sanjayda. Before leaving the session, I have found two questions in the inbox. That two questions are for me, I think. I am giving the answer, then I am leaving. First of all, the intravenous ketamine versus intravenous lignocaine, which one is better? I have found, I have studied this on in so many journals. It has been mentioned that though intravenous ketamine is more has more analgesic property, but it is not encouraged to use because of its adverse effects. Even it has got anti-convulsant property also, but so many adverse effects like patient becomes restless, post-operative nausea, vomiting is there. So intravenous ketamine is not popular, number one. And number two, question was, can we use intravenous lignocaine for cancer pain? Yes, there are recommendations, but all those recommendations are not level 1 or A category. All are B and C category, or level 2 or level 3. So in case of refractory pain, we may use it, but no supportive documents are there. Okay. Thank you so much. So with the permission of all of the seniors and the colleagues, I am leaving. Okay.
Yes, the presentations were really good today.
Use of intravenous lignocaine is cancer pain. In fact, I also had this query in mind whether to use in palliative care patients this lignocaine. So, but I have not, as Devanjali said, I have not found any evidence suggesting that desensitization with lignocaine will lead to decrease in cancer pain because it mostly helps in fibromyalgia. Having cancer pain has also additional fibromyalgia that can be helped, but no evidence has been found. But I wish to use it someday on cancer pain to try and find out.
During the operation, in the perioperative period or intraoperative period, is there any evidence of using IV lidocaine or the increase the depth?
Sir, sir, can I add some one point to it?
Yes, please.
If there is.
Actually, Subrata,
So actually,
yes, please. Yes, Tanuma.
sorry.
Yes, Tanumay, then Ramapati. Yes.
Then there has been a particular mixture available, and there has been studies going on known as Shiv mix. It has been introduced by one of the Indian anesthetists. What he does is he incorporates magnesium, IV lignocaine, and he religiously administers it before the incision is taken as a part of preemptive analgesia. And the results till now, whatever they are getting and they are publishing, is good.
Regarding lignocaine infusion in cancer patients during pre-op or intra-op, I can say in my institute I have not seen. It is not recommended still in my institute for patients.
I think you will remember there was one senior anesthetist in Kolkata who tried a lot, maybe some 15 years or 20 years back, to give intravenous lidocaine. And we have seen also some morbidities as well as very difficult outcome. So that's why I was asking. So it was tried here too. Any Ramapati, please.
Yes, Joyantoda, are you there? Can you respond? Can you respond, Joyantoda? Are you there? No.
Okay, no. So Dr. Sannal.
Yes. As you were asking, first of all, I'd like to cross Sonomoy on what is the evidence for preemptive analgesia. Till now, there is no convincing evidence of preemptive analgesia. Shiv Kumar, I have read through this. He has been using it for quite a long time and has put up some studies. They seem to be quite robust. He seems to be confident. But then again, the very question of preemptive analgesia being materializing is in the very question. So we had been using preemptive analgesia for a very long time, discussing it. The second thing that I was referring to a paper where they have given intraperitoneal kainite, and before giving kainite, because kainite causes release of glutamate leading to an inflammatory reaction intraperitoneally, but before giving kainite, they were infusing intravenous lignocaine 30 minutes before, and they have found that the pain score or the response to the pain was much less in subjects who have been given intravascular lignocaine. Though this was not a human study, but then again, they have shown quite an important difference, and they have admitted, they have attributed one of the causes of the anti-inflammatory action of lignocaine is because of the decreased release of glutamate from the presynaptic nerve terminals. That's what they have come across. So, but for lignocaine, giving for a preemptive analgesia or intraoperative analgesia, there are quite a good number of papers, but actually, they have not come into the book. I'm not sure whether any textbook has having lignocaine IV infusion for an analgesic purpose on a regular basis. Jointoda, I think, will be able to tell. Some others, Gargi will be able to tell, or others, they will be able to tell. Yes, what is your take on intravenous lignocaine intraoperatively due for analgesia, as asked by Dr. Goswami?
Yes. I was also thinking of him. ভলিউমটা কমিয়ে দিন। Yes.